Thank you. Your Excellencies, my Lord Bishop General, gentlemen of the press, distinguished ladies and gentlemen, I welcome you all to the 107th Inaugural Lecture. It is my pleasure to invite the Vice Chancellor, Professor Ayodi Alabola, to chair the 107th Inaugural Lecture open. Thank you.
The principals of the university, provosts, deans, professors, president, head of department, member of Senate, other invited events, and distinguished inaugural lecturer of today, and the family, my dear students, on behalf of Senate of this great university, I hereby declare open the 122nd inaugural lecture of this university. Thank you.
Ladies and gentlemen, this 122nd inaugural lecture is to be delivered by Professor Shelby Akintayo of Therefore, I invite the Vice Chancellor to introduce the inaugural lecturer of today. Vice Chancellor.
Ladies and gentlemen, it's my pleasure to introduce to us the inaugural lecturer of today, Professor Shelby Akintayo, who was born on 29th of April 1963 into the family of Mr. and Mrs. Samuel Obatola Ogutola. We went to Baptist Primary School in Okada, Lost State, where he finished in the year 1977. He later attended the community grammar school in the same community in Okada from 1979 to 1984. He was the social prefect of that school and thereafter proceeded to Hawaii Islam, Madhya College, Agege, in Lagos, his higher school certificate in 1984. He did not, however, complete his higher school certificate before getting admission into Olabisi Onawajo University, formerly Ogunde University, in 1986, to study medicine. He obtained his Doctor of Medicine and Surgery in 1994 due to disruption in the academic career during his study in the university. He commenced his residency training in internal medicine in 1997 at Olabisi Onawajo University Teaching Hospital and finished in 2004 with fellowship of the West African College of Physicians. He later joined the services of the University as a lecturer one in November 2005, honorary consultant of the Olabisi Onawajo University Teaching Hospital same year. He then proceeded to South Africa and did an absence in 2006 for further clinical exposure at Harvard Nuclear Central Hospital, divided from March 2006 to June 2006. By the date of that work, rose to the level of a professor in October 2020. In recognition of the social text, Professor Ogutola has at various times been appointed to serve in different capacities at many levels. At the university, he was acting head of the department of several occasions, the establishment officer of the department, departmental representative of Congress, member of the faculty research committee, representative of roles of the university academic ceremonies committee, and chairman of the faculty of political science quality assurance committee in 2023 convention of the field. As also to sign was the departmental representative on the transition committee for several years, was completed the training from 2016 to 2018. He has also served as the founder chairman of the governance unit in 2023. Of course, as a medical and dental consultant of the station level, by the time the secretary of the association, the vice chairman, and then the chairman of the association between 2014 and 2016. Since 2023, he has been the medical editor of the Association Journal of Annual Health Research. A highly accomplished scholar, Professor Ogutola has demonstrated exceptional intellectual ability from a young age. From early secondary school years, he started by winning numerous prestigious awards, a testament to his dedication, hard work, and remarkable academic aptitude. He won several prizes during the final school examination and had the best results in the final West African School Certificate examination. During his university study, that topic was the factor. During his university study, he won the third place award in the World Health Organization Essay Competition in 1992. He was presented the award. And was presented the award by the late Minister of Health, Professor Ogutola. Also won the award of second position in the essay competition amongst those in the Nigerian Medical College in 1993. This researcher of proven track record in 2016 became the first African doctor to receive the Dr. General Travel Bursary of the British Society for Rheumatology in the United Kingdom. He was at the time the director of the African League Organization for Rheumatology and was the pioneer president of the Nigerian Society for Rheumatology between 2014 and 2024. He obtained the certificate in rheumatology of the British Society of Rheumatology in 2010 and Doctor of Medicine of the National Postgraduate Medical College of Nigeria in 2023. He is a fellow of the Royal Institute of Health Technology, a profit writer and academic par excellence. Professor Ogutola has published widely in his area of specialization, both locally and internationally. He has 80 publications in his study. He has equally attended several conferences and meetings within and outside the shore of this country. He's also a usual of several academic and professional journals, among which are the National Medical Journal, the US-based Medical Journal, the Nigerian Medical Practitioner, and the Nigerian Hospital Practice. He is the editor journal for medical and health development, the resource person to pharmaceutical company, Pfizer, and GSK for continuing medical education. And subspecialty in head, specialty head in rheumatology, internal medicine, Western College of Physicians. Our inaugural lecturer of today is a member of several political bodies, including British Society for Rheumatology, International Association for the Study of Pain, African League of Associations of Rheumatology, Medical and Dental Consultant Association of Nigeria, and Nigerian Medical Association, among others. Besides this resourceful researcher, it's a wonderful wife, Mrs. Comfort Rheumatology, and the man is happily blessed with successful children, including his son, that African are taken to abroad and cannot see today. This evening, ladies and gentlemen, please join me in welcoming Professor Tebu Rheumatology to deliver 127 inaugural lectures.
The first person of that, the Deputy Vice Chancellor, Academic and Administration, other principal officers of the university, provost of the postgraduate school and other colleges, deans of faculties and the student affairs, professors and distinguished members of Senate, my Lord, spiritual and temporal, family members, colleagues, and friends from sister universities and institutions, distinguished ladies and gentlemen, gentlemen of the press, great old times. This lecture is titled Joint Diseases and Internal Organ Complications on Mastering Immune Tolerance Breakdown and Recovery. Mr. Chancellor, please permit me to state the obvious about this topic and rheumatology as a whole. The word rheumatology is new and foreign to some people, but to those who have slight understanding of the word, it denotes the disease of the joint. Some other interchange rheumatology with rheumatism and arthritis. Permit me, sir, to make a distinction between these words. Rheumatology is a branch of medicine devoted to the evaluation of musculoskeletal disorders and connective tissue diseases, including arthritis and soft tissue lesions. Its manifestations are not limited to joint and soft tissues, but can manifest on the skin and internal organs, such as the brain, the lung, the heart, and the kidney. Rheumatism, on the other hand, is a layman language. It means disease of disorder of affecting the extra-articular structures, like tendon, ligament, muscle, and muscle. All the time you see our patient, they tell us, doctor, I have rheumatism. But the actual medical term is pain originating from structures outside the joint. Arthritis literally means joint inflammation, joint pain, or joint disease. It affects structures within the joint, like the capsule, synovium, and the articular cartilage. I must say, we have over 200 causes of arthritis. Some medical practitioners find it difficult to differentiate cases to be seen by the rheumatologist and cases to be referred to the orthopedic surgeon. Mr. Vice Chancellor, sir, please allow me to make this clarification. Non-traumatic diseases are in the exclusive purview of the rheumatologist, while traumatic diseases are to be managed by the orthopedic surgeons. However, non-traumatic diseases that need surgery for different reasons, maybe because of unrelated pain or correction of deformity, are then referred to the orthopedic surgeon. The rationale for this inaugural topic. This topic was chosen in order to bring to the fore the involvement of other organ systems in disorder of joints and to spread the multidisciplinary approach to the management of rheumatic diseases. Breakdown of immune tolerance is the culprit in internal organ involvement in rheumatology. A brief history of rheumatology in Nigeria. The father of rheumatology in Nigeria is my trainer and my mentor, Professor Olufemi Oladipo Adilowo. He's a brilliant of rheumatology in Africa and a Grand Master of Rheumatology who parades the highest award of American College of Rheumatology. He was the first to be trained in rheumatology in Nigeria. The second person after Professor Adilowo is Professor Ola Adebayo. He's a professor of rheumatology in Sheffield in the United Kingdom. He does not practice rheumatology in Nigeria. Professor Adilowo was the only rheumatologist in Nigeria for so many decades. And our university, Autoimmunity University, was the only university in Nigeria where rheumatology was being taught then. He taught me rheumatology at my undergraduate level. I did my residency training under him. He has trained over 60 rheumatologists in Nigeria, in 6 geopolitical regions of this country. However, half of these professionals have left the shore of this country. Few of them that you train have become professors, few are readers, and many are senior lecturers. Some are practicing presently outside the country in different capacities. We have all adult rheumatologists, but we also attend to pediatric rheumatologists. Presently in this country, we have just one trained pediatric rheumatologist who completed a training 2 years ago. I find myself in this field of medicine. In the year 2002, after my part 1 professional examination of the West African College of Physicians, deciding on subspecialty to join was quite difficult for me. So I then interacted with Professor Christopher Olutayi and Professor Olumide Edward Ayodele, who were and until my close allies. The two of them consider rheumatology subspecialty to be great fit, since there is only one person in the area in the country. I put this into consideration, and I made up my mind to go to rheumatology based on 2 factors. I consider the personality of Professor Adilowo with regard to the project he related with us there. And second, I consider the reality of consultant in that field. If I may borrow from a quote of Robert Frost, he said, 2 roads divided in the world, and I took the less traveled by, and that has made the difference. I began my subspecialty training in rheumatology under Professor Olufemi Adilowo. It surprises me to say that Professor Aishat Akukube joined me in the training before she diverted to dermatology subspecialty. She is today a consultant dermatologist at the Lagos University Teaching Hospital. After completing my training in Nigeria, I went to South Africa for 3 months for further exposure. Was instrumental to all the arrangements, and I feel thanks to him. The journey so far, Mr. President, I have spent over 2 decades taking care of patients who suffer autoimmune conditions. Right From my days in postgraduate training at the University Teaching Hospital, Shaga, and as a consultant rheumatologist within and outside the country, I built the knowledge acquired in the management of patients to train and mentor generation of medical students in our university and the postgraduate doctors in the teaching hospital in the last 20 years. I am standing before this audience today to present my experience and encounter with this group of patients. Rheumatology and autoimmunity. The concept of rheumatology or autoimmunity describes antibody formation against the body and attacking cell tissue. Antibodies are the shoulders of the body that protect the body against foreign invaders. Normally, these antibodies tolerate the body cells by not attacking them. This is referred to as immune tolerance. Antibodies are unable to tolerate the body cells and tissue again. Then we say that breakdown of tolerance. Then the antibodies begin to attack body cells, not recognizing that they are part of that body. And in this case, we say that we make use of the term autoimmunity. The body immune system is designed to accurately identify potential sources of harm to the body. In order to do this, they will fail to mount appropriate protective response to the threat posed by the invading organisms, and therefore rapidly succumb to the organism. Secondly, they inappropriately mount an unnecessary response to molecules of origin, and consequently they attack, destroy the whole tissue as then. The immune system is therefore highly proficient in ensuring that these things are not played out. Occasionally, some pathogens successfully evade and survive the immune response. And in some cases, the immune response will inappropriately target the host material, leading to production of autoantibodies and then autoimmune condition. Autoimmunity and autoimmune diseases. Autoimmune disease represent a significant dead body that is in about 3 to 9% of the general population. The immune system must be effective enough to defend against a diverse number of pathogens. At the same time, they must maintain tolerance to certain antigens. Autoimmune diseases are classified as systemic or organ specific. The systemic categories include systemic lupus erythematosus, rheumatoid arthritis, and scleroderma, systemic spondylitis. In systemic autoimmune disease, organ injury is typically mediated by autoantibodies and less commonly by T cells. In organ-specific disease, however, end organ damage can be mediated by autoantibodies or by T cells. Examples in this category include thyroid disease, type 1 diabetes mellitus, autoimmune hemolytic anemia, and myasthenia gravis. The cells of the immune system. The immune system, as earlier mentioned, are to defend the body against foreign invaders. This can be likened to the security outreach of a country. We have the army, which are the land, security outreach, we have the air force, the air, talking on the air, and we have the sea, the navy. And there are also other military agents, like the police, civil defense, manpower, and Boy Scouts. And these people, this army is also render assistance to the military where awareness is. As we have army in arranged in battalions, immune system are arranged in different categories. They are always ready to attack any very invader into the body. The immune cell comprises of granulocytes, the monocytes, antigen-presenting cells, natural killer cells, proteins, and peptides. The immune cell comprises of granulocytes, monocytes, and proteins and peptides. Composition of the immune system. The immune system comprises of two arms. Innate, which is acquired from birth, and while the adaptive one, which is acquired as a result of exposure to antigen after birth. The immune system is usually the first, the innate one is the first to initiate immune response to pathogens because of its ability to be activated by different microbes. And on the other hand, to activate the adaptive immune system. The adaptive response has more protection because they recognize so many antigens and because they have memory of previous encounters. Just like the armies are involved in the ability of the police to arrest a case in an area is devoid or they do not do it, then the armies are mobilized. Same thing, the adaptive immune system are mobilized to join the innate immune system to act against the organism and to defeat them. Innate immune system composition. We have the physical barrier, the skin, the villi in the gut, and the cilia in the respiratory system. The lymphocytes, we have the neutrophil, monocytes when they are in the blood, and macrophages when they are in the tissue. We also have the natural killer cells, the complement system, cytokines of innate immunity, protein of innate immunity. The main functions of the innate immunity system include one, clearance of foreign and potential detrimental cell materials through the improvement and activation of immune cells. Number two, activation of the complement pathway. And three is the triggering of adaptive immune response. Regardless of number of exposure of the innate system to specific stimulus, this results in induction of non-specific, generalized inflammatory response. As such, a repeated exposure to specific immune stimulus will lead to response identical to the initial one. The innate response, in essence, is immediate. Recognition of pathogens. The content of the dying cell or from other type of foreign material or danger signal lead to induction of a measurable response, physiological response within a matter of minutes. So the immune system derived from birth is like rapid response birth. They are always ready, they are mobilized for defense immediately. The adaptive immune system composition. Activation of the immune system after that. It's a much more complicated process that involves multiple cells, extensive communication between cells, and induction of cellular proliferation. Consequently, it does not happen so quickly, and can experience a delay of 3 to 5 days from stimulation, with a brief response not beginning to occur until about 7 days post-stimulation. It will take some time for the armies to be mobilized to join the police if needed. So it is the same thing with the immune system that survive after that. There may be a little bit of delay before they are stimulated to join the innate system. The adaptive response begins with recognition of antigen presented by the antigen presenting cells, such as the macrophages and the dendritic cell. This leads to the stimulation of T and B cell proliferation from a process known as clonal expansion. Differentiation of the T and B cell results in antibody secretion from the B cell and direct killing by phagocytic T cell. T cell response being first, and the antibody titer gradually increases in time. The number of T and B cells will return toward the simulation level because of cell death, a control cell that will refer to as apoptosis, which is programmed cell death. However, some cells will not die, but persist for a very long period as memory cells. As mentioned earlier, the magnitude and nature of the innate response are identical upon the stimulation with the same antigen. However, this is not the case with the adaptive response. With the immunological response, the first exposure to adaptive system creates primary response. The next exposure is secondary response. The secondary response occurs and it's stronger, very stronger than the primary response as a result of presence of the memory cells. Remember the antigen. This time, the example infection may be clear even before they become symptomatic. The main constituent that is adapting from the immune system are the B and T lymphocytes. In aggregates, the pool of lymphocytes can recognize partially antigen. After the process of selection, lymphocytes that are beneficial are extracted and retained. Those properties allow the immune system to detect failure foreign antigen and to respond rapidly and specifically to secondary challenges. T cells arise from the thymus, where they undergo defined maturation stages. They are positive and negative clonal selection. These cells develop in the bone marrow and undergo defined maturation stages and selection of antigen receptor. The body has a way of removing malformed baby from the uterus. So the same way, body is capable of removing those cells that have ability for stem cells. They remove them or they are deleted from the system even before maturation. The adaptive and innate immune response were originally believed to function independently. However, it is now clear that they are in fact intrinsically linked. This can be likened to the action of the Navy, Air Force, and Army when they are attacking the federal into the country. So the innate immune system will help the adaptive immune system in order to counteract the effects of the foreign body into the body. Tolerance mechanism. Increasing insight into mechanism of tolerance and demand over the past decades in parallel with growing knowledge of the immune system. More than 50 years ago, Bonnet and Malawa advanced the critical concept that tolerance was imposed by human division of reactive lymphocytes during early development. Immune tolerance, or what we refer to as immunological tolerance, is a process by which the immune system does not mount immune response on self-antigen. It occurs in three forms. We have the cerebral tolerance, we have the cerebral tolerance, and the acquired tolerance. Both B and T cells can be made tolerant, but it is more important to be tolerant to T cells because B cells cannot produce antibodies against most antigens with the help of T cells. Tolerance is central. If it operates in the tolerance in the lymph node, in the lymph organ, that is the thymus and bone marrow. And if it operates at the peripheral lymph organs, that is the lymph node and the skin. The exact benefits of immunological tolerance is still elusive. But several theories have been proposed. Three hypotheses are gained that spread attention. Clonal deletion theory, proposed by Bonnet, according to which self-reactive lymphocytes cells are destroyed during the developmental stage of the immune system in an individual. Two, the clonal energy theory, proposed by Nozar, in which self-reactive T and B cells become inactivated in normal individuals and cannot amplify the immune system. And the third one is the equal network theory, proposed by Jen, wherein a network of antibodies capable of neutralizing self-reactive antibodies exists naturally within the body. So when we talk of breakdown of immune tolerance, a breakdown of immune tolerance leads to autoimmune disease. This concept of autoimmune disease can be likened to the group of army officers that overthrow the ruling government or the legal government, be it military or civilian. There are reasons why coup plotters will want to overthrow the government. One, it will be because they are not satisfied with the method of governing of the country. Two, is that because they are poorly paid. Or three, is that because they also want to take power. So, autoimmunity will develop. If there is defect in any of these processes, one, failure to delete autoreactive T cells. Two, defective T cell activation and timely selection. Number three is defect in body process that is supposed to remove dead cells, that is apoptosis with programmed cell death. Number four is defective peripheral tolerance of T cells. Five, fungus activation of ignorant T cells. And number six is what we refer to as molecular mimicry. Some pathogens contain certain region on there which we call epitope, which resembles certain region of cell antigen. When the individual is infected by the pathogen, the immune system elicits response not only against the breaking of the disease, but also against cells and tissues of the body. And this then leads to autoimmune disease. Number seven is that genetic hormonal and environmental factor may also contribute to the development of autoimmune disease. Three things can happen when there's an attempt to overthrow the government. The government, the plan will be lead to the government, and the people are dismissed or summarily executed. And second is that they will actually carry out the coup. But because of the enforcement from armies that are loyal to the winning government, they are defeated. And number three is that they can actually carry out the coup and they are successful. So we talk of autoimmunity only when the mad immune cells are successful in attacking the body. And so we then say we are overtaking the government of the body. Successfully carry out. Few things can happen. There will be disruption of the government functionaries. The governors are flagged. The House of Senate, the Senate and the House of Representatives are flagged. The local government are flagged. And so when autoimmunity occurs, three things will happen. There will be loss of function of the affected tissue. Then suppression of the affected organ. And the thing is that there is impairment and destruction of multiple organs because of antibody complexes that are deposited in those organs and tissues of the body. Mechanism of tissue damage and in autoimmune disease. The same mechanism that is being used to neutralize invading pathogen that get into the body are also used in autoimmunity to invade one area of the literary thread on molecules, cells, and tissues. The mechanism involved are complex. This is called hypersensitivity reaction and has been grouped into four groups or four types. Although in a number of autoimmune diseases, more than one mechanism may be involved. Type 1 is what this is acute type of reaction. Vasoactive substances are released by the pathogen and the mast cell. This is the type of reaction we see in drug reaction, like septic. We have widespread eruption on the skin. Type 2, this is mediated by antibody directed against the surface cells. An example is when someone reacts to blood transfusion. Type 3, this occurs when antibody complexes are deposited in various tissues and organs of the body. And example is systemic lupus erythematosus and rheumatoid arthritis. Type 4 is a delayed type of reaction. Example includes tubercular reaction, fungal dermatitis, and when the body of the patient rejects the organ that is supplied to it. A common example is kidney rejection. Mr. Pastor, for the purpose of this lecture, we shall be looking at type 3 hypersensitivity reaction. That is immune complex reaction due to antigen and antibody complexes deposition in various tissues of the body. Mr. Pastor, we have to say that we have an entity that we refer to as immune privilege. Immune privilege is a term to describe certain types of body that are able to tolerate introduction of antigens, like organ transplants, without attacking the transplanted organ. Tissue grafts are normally recognized as foreign antigen by the body and attacked by the immune system. However, in immune privileged sites, Tissue graft can survive for an extended period of time without rejection. The immunological privileged organs in the body are the heart, the brain, the ovary, the testes, and the baby in the womb. The explanation of this phenomenon is that physical barriers around the immune reflex type to avoid infection from the immune system. Physical structure surrounding reflex type cause a lack of lymphatic drainage, limiting the immune system ability to enter the site. If you take, for example, the baby in the uterus, if the baby not being attacked by the immune cells, since they are formed from foreign antigens, that is sperm, meeting with the ovum. The simple explanation is that placenta prevents baby from being recognized by the self-reactive immune cells. And secondly, the covering of the baby, that is the amniotic baby, is devoid of lymphatic drainage. And so the baby is shielded away from self-reactive maternal cells. Rheumatology and interpretation with other specialties. The title of this inaugural lecture actually emanated from the relationship of rheumatology with other specialties in medicine and other specialties outside internal medicine. To some people, rheumatology is synonymous with joint disease. This lecture will, however, correct this notion. Rheumatology is more than joint disease. The scope of rheumatology includes joint disease, connective tissue disease, such as systemic lupus erythematosus, rheumatoid arthritis, scleroderma, vasculitis, and metabolic bone disease. Rheumatic disease could affect virtually all the organs in the body and related to other specialties and other fields of medicine. Some of the rheumatology conditions can act over present to the kidney doctor board, the heart doctor board, or the eye doctor before they are eventually referred to the rheumatologist. Mr. Dr. Sir, can they allow me to give a detailed account of how rheumatology is related to other systems and for specialty in terms of disease, joint disease affecting other internal organs in the body? Citing various aspects of my research work, the body organ involvement and my research findings. When the body has failed to recognize some of components as failed, then we say that's breakdown of tolerance. The antibodies that are supposed to attack body failure to the body, then begin to attack body components. As they say, there is autoimmunity. The body soldiers attack the body tissue, which they consider as foreign. The interaction between antigen antibody results in antigen antibody complexes that are deposited in different tissues of the body and result in abnormal function of those tissues and organs. Permit me, sir, to start with internal medicine of specialty before considering other of specialty. I would like to start from the brain downward. The brain, the heart, the endocrine system, finally, the protective function of the body. Other specialties of specialty will not be left out. The heart, the abdomen control. And objective development will not be left out. The brain and the connection. Rheumatic diseases can affect the brain in various ways. Systemic lupus erythematosus, which is the prototype of connective tissue disorder, will manifest as difficulty in memory and listening, headache, convulsion, spinal cord lesion, acute functional state, and other psychiatric problems. Neurological manifestation of SLA include non-bacterial inflammation of the brain covering, stroke, movement disorders or movement abnormalities, and multiple nerve problems within and outside the brain. The study by unnecessary by Acknowledgements and Autoimmunity, which examines the pattern of systemic lupus erythematosus among Nigeria, show the different manifestations of SLA as highlighted above. Autoimmunity and Acknowledgements also study organ involvement systemic lupus erythematosus in a Nigerian teaching hospital. Study the neuropsychiatric system in lupus erythematosus involvement among Nigeria. And multi-center descriptive hospital-based study of SLA in all rheumatology centers in Nigeria, and investigated the pattern of systemic lupus erythematosus in Nigeria. there were no significant differences among all the geopolitical regions of this country. When the CLA is associated with an entity that we call anti-phospholipid antibody syndrome, the presentation will include blood clot formation in the brain, right, increased blood pressure in the brain, and multiple impact dementia. Reactive with anti-phospholipid antibody syndrome result in bleeding into the brain. Our study on anti-phospholipid antibody syndrome among Nigeria showed the different manifestation of this disease. Rheumatic arthritis, which is a typical example of inflammatory arthritis, may cause some friction of the spinal cord, and therefore patient may present weakness of the leg and of the hand. This occurs when the bone of the leg are affected. A single or multiple nerve may also be affected, causing tingling and numbness of the affected part of the body. Patients with acute rheumatic fever can present with abnormal movement of the head, the tongue, and the upper lip. Condition we refer to as hematuria. Inflammation of the pipes, that is vasculitis. Apart from the constitutional symptoms of fever, loss of appetite, weakness, and weight loss, can result into abnormal function of the brain and weakness of one side of the body. The blood pipe of the brain is being affected. Many nerve involvement is also a common vasculitis, which may affect the upper and lower part of the body. Disorders are clot formation in the brain, bleeding into the brain, abnormality of the hormone-producing organ of the brain, severe headache, convulsion, and liquid accumulation in the brain. Okotoman and Echor look at the clinical spectrum of breast cell disease among patients in at the Tertiary Rheumatology Center. This disorder causes a painful involvement of the electric transmission routine and outside the brain, bleeding to the brain, blood clot formation in the brain, and spinal cord abnormality. The heart and the blood vessel. The heart and the blood pipe are affected in different ways by the tissues of the joint and the connective tissue. The blood supply of the heart and the layers may be affected. The heart covering, the muscle, and the heart part may be affected. In the study by Autoimmunity and Adelor, the northern involvement, the systemic global group in the Nigerian teaching of people. The cardiovascular system was one of the leading organs affected by SLA. The heart manifestation include inflammation of the covering of the heart, rate of recharge fluid accumulation, occurring in more than 50% of SLA patients during the course of their disease. Parents occur in setting of active SLA in other organ systems. Inflammation of the heart muscle to present as heart failure or enlargement of the heart. Increased heart rate and abnormal conduction system of the heart. Familiarly and Okotoman look at the conduction system of the heart and now it's affected by rheumatoid arthritis. The gates of the heart, which are responsible for the inflow and outflow of blood, may be damaged in patients with SLA. Damage to the heart gate result in backflow and reduced flow of blood from the heart. It may result in inflammation of the heart lining. The heart gate or the left side of the heart are commonly affected. All these conditions can lead to failure of the heart to function well. Fat deposition in the heart part of the heart is a well-recognized complication of blood changes in terms of erythematosis, which could lead to disease of the blood pipe supplying the heart. Disease is lymphoma, can be characterized by involvement of the heart gates, heart lining, heart muscle, and covering of the heart. The heart involvement may present as abnormal electrical activity of the heart, backward flow of blood into the heart, reduced loss of light in the heart muscle, enlargement of the heart, and failure of the heart, as exemplified by the study of Okotoman et al. In systemic sclerosis among patients attending rheumatology clinic of a tertiary institution. Rheumatic disease that affect the heart include muscle disease of unknown cause, causing what we describe as abnormal electrical in the heart. This can be likely to various electrical transmission abnormalities like short circuit, low circuit, slow heart rate, exaggerated heart rate, irregular heart rate, and then heart failure. Rheumatoid arthritis heart muscle abnormality and eventual heart failure. Inflammatory condition of the blood pipes can cause failure heart disease such as backflow of blood into the heart, blood clot within the heart, and abnormal dilatation of the heart. All these conditions can lead to failure of the heart and therefore increase the risk of premature death. You can see that photograph that is showing computerized program showing the dilatation of the sending organ in a patient with pancreatic disease. The lung. Lung disease can be seen in patients with rheumatic condition. Inflammation of the lung opening. The catheter fluid accumulation in the pleural space, bleeding into the alveolar space, and abnormally high blood pressure on the pipe of the lung. Condition can affect the lung to a degree includes erythema, muscle disease of unknown cause, vasculitis, and rheumatoid arthritis, as demonstrated in study by Adebule and Ogutono. In rheumatoid arthritis and pulmonary fibrosis in Nigeria, and Ogutono et al. In cardiopulmonary manifestation of rheumatoid arthritis among rheumatology patients of a tertiary hospital. Patients with antiphospholipid antibody syndrome may present with increased pressure in the blood pipe supplying the lung. This may develop due to recurrent blood pollution. Usually, there will be presence of bleeding within the lung. Lung involvement is found in most scleroderma patients. Hypertension of the lung pipe of the lung tissues are the major causes of death in scleroderma patients. After this to develop severe progressive lung tissue damage has been observed among African patients. Lung tissue disease may manifest as declining lung volume and lung fibrosis. It will merely cause accumulation of urea in the chest, adult respiratory distress syndrome, and bleeding into the lung. Patients with blood pipe disease supplying the lung may present with difficulty in breathing and failure of the right side of the heart. Lung involvement in this disease will lead to severe limitation of quality of life for patients and progressive failure of the lung. Weakness of the lung muscle is seen in patients with muscle disease of unknown cause and may also damage the lung tissue. Survival is usually poor in patients with diffuse bleeding into the lung. Condition causing inflammation of the lung pipe of unknown origin will also affect the lung to a great extent. Patients may present with persistent dry cough, breathlessness, inflammation of the lung lining, coming out of blood, widespread bleeding in the lung, and lung fibrosis. And abnormal dilatation of pulmonary artery is a finding is a possibility condition. Rheumatoid arthritis may present with inflammation of the lung covering, inflammation in the lung covering, lung fibrosis, and increasing pressure of the lung blood pipe. You can see that photograph. Right side the rheumatoid arthritis patient. The digestive system. The digestive system involvement yesterday can involve any part of the food passage from the mouth right to the anus. Difficulty with swallowing and decreased movement of food downward is most commonly observed in the upper one-third of the food passage. Abdominal pain can be due to exercise-related causes, medication side effects, or non-exercise-related causes such as infection. Exercise-related causes of abdominal pain include inflammation of the peritoneum, disease of the pancreas, and blood pipe supplying guts. The small bowel is more frequently involved than the large bowel in reduced gut motility, and patients may present with abnormal abdominal pain, feeling of vomiting, abstract vomiting, and abdominal swelling. Exercise patients may also pass a lot of protein from stool, leading to reduced protein in blood. They may therefore present with leg swelling and abdominal swelling. Scleroderma may affect the food passage from the mouth to the anus. Patients may present with difficulty in chewing, inability to open the mouth wide, enough for proper dental care, and provide large, solid food. Reduced saliva production in scleroderma further leads to difficulty in chewing, food sticking between the teeth, and therefore tooth disease, and looking of teeth further affect chewing capacity in scleroderma patients. Problem with initiation of swallow may lead to coughing and increased risk of aspiration of food. Difficulty in swallowing is the most common food passage problem in scleroderma patients. Other complaints are heartburn, backward fluid, and food, painful swallowing, and feeling of vomiting. Involvement of the food bag, that is the stomach, We need to delay of movement of food to the grinding portion of the intestine. The patient will therefore present with pain and bleeding into the stomach. When disease affects the grinding portion of the abdominal portion of the food passage, patient presents with constipation, abdominal swelling, diarrhea, inability to absorb protein, resulting in protein loss from food passage, and leakage of feces from the anus may also occur. Patients with muscle disease of unknown cause may present with difficulty in swallowing, backflow of water into the food passage, and food to the lung. Reduction of quantity and quality of saliva produced by patient with Sjogren's syndrome will result in dry mouth. Therefore, they present with difficulty in chewing, difficulty in swallowing dry food, and change of taste. Reduced saliva production probably result in dental caries, cracked teeth, and loose dental fittings. Previous inflammation of the blood pipes may present with abdominal pain, bleeding, diarrhea, liver, and skin disease. Less common presentation include appendicitis, inflammation of the pancreas, and that of the gallbladder. The kidney involvement in hematology is commonly encountered. The involvement will be because of disease process or because of the drug that we use to treat it for the patient. Kidney involvement is common in SLA and a significant cause of ill health and death. Most of the patients will develop kidney involvement within 10 years of onset of SLA. The presentation includes reduced urinary output, protein and different types of urine. Some may also present with bloody urine, which may be detected under microscopic examination. There may be body swelling as a result of fluid accumulation because of inability to pass urine and eventual kidney failure. The kidney involvement may eventually lead to problem in other organs. When the level of waste product is so high in the blood, it will lead to failure of the heart, difficulty in breathing, and convulsion. Kidney involvement in scleroderma is usually present as acute kidney injury, and patients will present with sudden rise of blood pressure leading to fast onset of kidney failure. Other presentations include headache, heart damage due to hypertension, brain disorder, and fluid in the lung. Long-standing rheumatoid arthritis may lead to excessive precipitation of protein in the brain with another kidney failure. Previous inflammatory condition of blood type can also affect the kidney, the reproductive organ, and the urinary system. Patients may present with passage of blood in the urine, red blood cells in the urine, inflammation of urine passage, and abnormal dilatation of kidney blood pipes. The urinary tank may also be affected. Gout, which we often refer to as deposition of bad salt in the joint, may also affect kidney suddenly or gradually. Long-standing kidney disease occur when the level of bad salt is persistently high. The muscle, systemic lupus erythematosus patient may present with muscle pain, but through inflammation of muscle extremity area. The scleroderma patients, a few of them have inflammatory muscle disease that can both be same cause as muscle disease of unknown cause. They can present with muscle weakness of the proximal part of the body, like the shoulder and the hip. Disease of the heart muscle and failure of the heart will result from muscle disease of unknown cause. Microarthritis patients have muscle weakness, but only a few of them have tenderness on examination. One of the blood pipe diseases that we call giant cell arteritis may be associated with muscle pain of the jaw, the extremity, and the tongue, and muscle involved in swallowing when they are put to use. Hematology, the major component of blood cells, the bone marrow and hepatic structure may be affected to a varying degree in patients suffering from rheumatic disease. Blood cell involvement is common in SLA. All the 3 lines may be affected. Shortage of blood due to chronic illness is commonly seen. And shortage of blood will be as a result of destruction of red blood cells by the user or by the enlarged spleen. Presence of blood white cells is also very common in SLA, and usually due to reduced lymphocyte component of the cell. Both mild and severe reduction of platelets will be seen in SLA. The platelet reduction can result from destruction of immune cells or a large pain. The part draining the lymph node, the lymph, may also be affected, and different regions of the body may be affected. Commonly the neck, the hand, and the groin. The skin may also be rendered functionless. Most patients with rheumatoid arthritis, they have low-grade blood loss and shortage, and they may also present with increased platelet count. Shortage of blood is also commonly seen among various rheumatologic conditions, such as the inflammatory condition of the type, that is arthritis, and unknown arthritis in children. Hormonal issues. Hormonal abnormality can complicate cause of management of cerebral patient. The most commonly seen hormonal abnormality is thyroid disease, and hypothyroidism or low thyroid disease is the commonest seen. Erectile dysfunction and associated impotence among male cerebral patients are common. Patients with type of blood or polyarteritis nodosa may present with testicular pain from reduced blood supply in the testis. However, it's a very uncommon presentation. The skin is not left out. When we talk of immune tolerance breakdown, skin and mucous membrane may be involved in patients with systemic lupus erythematosus. Both regenerative and non-regenerative hair loss may be seen. Acute mouth lesions may present as breast mucus erosion, ulcer in the palate and mucous mucosa. Skin problem necessarily to occur on different lesions, and that is minor rash and much ulcer in the patient with test syndrome. They also see the patient with test syndrome and subacute lesion in the patient with test syndrome. Skin color changes, the phenomenon we refer to as pregnant phenomenon. It's like exaggerated vascular response of the finger and arterial circulation triggered by cold weather or emotional stress. Seen in patient with scleroderma. Skin color changes can be seen. However, these color changes is difficult to see in black skin, but can be readily seen among white people and the light complexion people. Following several skin changes in scleroderma, the skin eventually becomes thickened as a result of excessive collagen deposition, and therefore permanent contraction around the joint. You can see the skin change in semester scleroderma, what we refer to as salt and pepper distribution, and the hard skin seen in that patient. Skin fibrosis due to change in appearance of face, reduced mouth opening, skin ulcer, will develop especially at the site of trauma, such as the finger. You can see the ulcer and reduced mouth opening in that patient with scleroderma. Various skin changes are seen in patients with muscle disease of unknown cause. Rashes may be seen on the face, including the high ridge, the neck, the anterior chest wall, the finger, and the elbow. The most frequently recognized skin lesion in rheumatoid arthritis is rheumatoid nodus. Due to insufficiency blood supply can be seen. There can be vascular lesion on the leg of that patient. In that patient, however, there is deposition of salt on the skin. This filter will be deposited on the ear, and we can see that in that patient and also on the external conditions of the digits. The eye, especially can affect the various ways. The most common manifestation is dry eye due to reduced tear formation, to moist the eye, mucous membrane. Other presentation include inflammation of the covering of the eye and bleeding into the eye. The dry eye is the result because of skin fibrosis around the eye, preventing full closure of the eyelid. There is a danger of blindness in patients with rheumatoid arthritis. Blindness occurs as a result of perforation of the anterior chamber of the eye. Eye syndrome in patients with scleroderma syndrome may include prettiness and body sensation, inability to look at light, and eye weakness. So many other rheumatologic conditions can affect the eye. The presentation may include double vision, visual loss, bulging of the eye bulb, weakness of the eye muscle, obstruction to the flow of tear, damage to the nerve supplying the eye, and blockage of the blood pipe of the eye. Others include post formation, glaucoma, and cataract. The ear, nose, and throat. Certain inflammatory rheumatic conditions may affect the fourth portion of the ear. Patients may present with sudden onset of pain, tenderness, and swelling of the affected ear. The ear becomes flabby when there is recurrent involvement of the back portion of the ear. The ear, nose, and throat may also be affected. And patients may present with blood stain nasal discharge, nasal crossing, inflammation will stand up the hair, narrowing of the parts of the throat, and hair loss, which may be partial or permanent. Other presentations will include middle ear disease, perforation of the septum of the nose, bleeding from the nose, collapse of the cartilage portion of the nose. The genitalia. Genital ulcer is part of manifestation of rheumatic diseases. The ulcer could be seen on the scrotum and pelvis in males, and also the vulva of vaginal mucosa in female. The genital ulcer has a greater tendency to scar, especially in patients with special disease. Obstetrics and gynecology. The female reproductive system development is not left in the disease of joint, and in fact, patients with joint disease may be presented to the gynecologist first before the referral is made to the rheumatologist. A condition we refer to as antiphospholipid antibody syndrome is associated with recurrent pregnancy hospital. Other pregnancy abnormalities will include hypertension, pregnancy, convulsion, and fetal loss in mother's womb. Sexual performance is often affected in patients with scleroderma, particularly in women with specific type of disease. They usually have reduced sexual satisfaction because of painful stiff joints, dry vaginal membrane, and general fatigue. For the category of patients, there is an increased risk of hypertension, kidney failure, and fetal death in mother's womb. And children also affected. Mr. Pastor, before I conclude the medical aspect of this presentation, many patients they tend to ask us if children are also affected. The answer is yes. Some of the diseases seen among adults are also seen among children. And in fact, the internal organs are equally affected. And sometimes the disease is more difficult to treat and more serious among the children than adult patients. My contribution to medical education. Mr. Vice Chancellor, apart from my journal publications, both as a leading author and co-author, totally over 17 publications. I have contributed to medical knowledge through dissemination of research findings, and also through publication for both undergraduate and postgraduate studies students, as well as editor of the Journal of Biomedical Health Development, and also the medical editor of Journal of Health Research, the Journal of the Medical and Dental Consultant Association of Nigeria, since 2023 up to this time. I have been a reviewer of peer-reviewed journals, both nationally and internationally. I'm a co-editor of the medical textbook with Professor Lukai leadership and Professor Lukai, including essential textbook of medicine and companion to tropical medicine, book published by over 170 authors within and outside the country. I also contributed a chapter in Simplified Complete Handbook on Diabetes, edited by Professor Leadership and Professor Autoimmunity. I also contributed a chapter in the Constant Textbook of Medicine, a book published by the Department of Medicine, Obafemi Awolowo University. The editors are Emeritus Professor Akishola, Professor Komolame, and Professor Mola. I also been research person to many pharmaceutical companies. I'm a research person at the public courses of the West African College of Physicians. I'm also an examiner of West African College of Physicians and a number of undergraduate medical students. Conclusion and recommendations. In the year 2018-2019, I was one of the Asian countries to practice medicine. The scope of my cases seen here are not quite different from the cases that we see in Nigeria. The difference, however, lies in the free access to medical care in that part of the world. The management of most rheumatic cases is quite expensive with the use of a drug that we call biologics. Biologics are expensive and they are the life-saving medication in patients with autoimmune diseases. The outcome of most diseases is relatively good in Asian countries compared with what we see in our country, in other like Nigeria, where patients pay out of pocket. People with health insurance coverage will not benefit from this biologic due to the fact that health insurance does not cover them because of the cost. One could imagine a dose of the biologic costing over $500,000. We will repeat the drug in 2 weeks' time, and we also repeat it when necessary. How many patients will be able to afford it. Autoimmune disease is not a respecter of social strata. As it affects the rich, so also it affects the poor. Mr. Vice Chancellor, sir, since funding is the main problem, denying our patients with autoimmune condition to receive best medical care, I would suggest that government should also look into this field of medicine and according the chronic attack to malaria and communicable diseases like tuberculosis and AIDS. I also advocate that the National Health Insurance Scheme should cover this medication used in diseases because of patients are able to pay out of pocket. Acknowledgements. So God alone be all the glory for everything He has done. Without Him, I am nothing. I do not take His love over me for granted. Praise be to His holy name. Appreciation goes to my teachers, those living and those of blessed memory. I sincerely appreciate Dr. Bakoya Senior of blessed memory for his role in making me to take to complete my residency training. My trainer and my mentor, Professor Olufemi Oladipo Adilo, words are not enough to express my gratitude to you. You are one in a million trainer. Professor Adilo gave his all to my training, especially being the first person to take after him the field of rheumatology in Nigeria. He did not limit his role to training alone. He also contributed immensely to the welfare of my family. You are appreciated, sir. May the good Lord reward you here and in eternity. He sent his apologies. He's presently out of country attending a rheumatology conference. I'm also supposed to be here, but for this purpose, I received warm support from members of my department, both academic staff and administrative staff. My academic senior and colleagues in the department are wonderful people. They've been so much love and assistance. I collaborated with some of them in research publication, and we also co-authored peer-reviewed medical books. My sincere appreciation to everyone. I appreciate the author, university principal officers, my college and faculty leadership for their support and friendly disposition. The first family here present are duly recognized. I sincerely appreciate my lovely brethren from Success Chapel and the Litany Soul of the First Black Church. The secondary school made present are also well appreciated. I thank my cousin and my big brother, retired Rear Admiral I.T. Osholani Oladusu, who was there for me throughout my medical school. He was the backbone, my backbone, and the pillar of support to achieve the purpose of God of our life. I only want to thank his wife and the children. They are simply wonderful. My dear sister, what a day in Kapakuku, Ni Oladusu. We are sincerely appreciated for your assistance. I also appreciate other members of the family that are too numerous to mention. My siblings are not left out. I deeply appreciate you all. The first fruit of our daddy, Pastor Ola's family, what they call Big Daddy, which Commander Olorunso Ogutono, may your soul rest in perfect peace. Sister Benicia Ogutola Ni Ogutono, Sister Mojirayo Ogutola Ni Ogutono. I'm grateful for your contribution to the person I am today. All my friends are expressly appreciated. They include Dr. Simon Olubade Olateju, who some people funded for by my twin brother. Just arrived from outside the country. Dr. Michael Adekoya, funded for Father Guye, we flew in from South Africa to witness this inaugural lecture. Dr. Olaka Gabriel Awudeli, Dr. Benaya James Martin, Dr. Adewale Daniel Adesoya, Dr. Adebayo Ariago, rest in peace, friend. Honorable Bola Julius Olabiyi, Olusola Adekunle, and Apostle Samuel Olabiyi, and so many others that time and space will not allow me to mention. My friend and senior colleague, Professor Christopher Olukayo Adejosu, and Olubade Adebola, whose advice I follow to specialize in pathology are duly appreciated. I don't know if you are there. Can you please stand up for recognition? Dr. Adejosu and my children, Oluwaseun Bibia Akinde ní Ògúntọ̀nà, Fúnmiláyọ̀ Kútúrà Ẹ̀kọ́ ní Ògúntọ̀nà, and Dr. Samuel Ọbáṣọlá Ògúntọ̀nà, who has been called by Jack Asino, are deeply appreciated for their love understanding and support. My grandchildren are just too wonderful. Olúwaṣeyí Mákindé, Olúwatamílọ́rẹ̀ Mákindé, Olúwanífẹ̀ẹ́ Mákindé, Aláyọ̀mídé testimony ẹ̀sán. I'm also not leaving behind my son-in-law, Akínlóye Mákindé and Ayọ̀lá ẹ̀sán. My daughter-in-law, Dr. Omotoke Ogunṣọ̀nà ní Ẹdun. My in-laws, Professor and Mrs. Ẹdun, you are well appreciated. Mr. Vice Chancellor, sir, this acknowledgement needs will be incomplete without mentioning the woman behind my success. We have been together for 44 years. From 3 in the secondary school. Distinguished ladies and gentlemen, I thank you most sincerely for your attention. Thank you.
Thank you. Once again, on behalf of the Valley Management, I welcome you all to this inaugural lecture. You will agree with me that the inaugural lecture has recognized most of us here today. We are all very, very important dignitaries. However, it matters that we must also recognize some special dignitaries in our midst today. I have the honor of recognizing Senator Adenega, the governor of the state. We also have in our midst Dr. Tabi Saliso, Pioneer University Librarian, Federal University of Agriculture. Ladies and gentlemen, I have the honor of welcoming the Vice Chancellor to declare this ceremony close. Vice Chancellor.
Once again, I have the honor of recognizing the principal officer of the university, and deans and provosts, and members of studies, invited guests, which all mention all their names today. I also added to my own lexicon so many times. I'm very sure that all of us have been different between arthritis, rheumatism, and rheumatology. Even that is only what people that is being done for today. For those that are interested in knowing more, the forms is still on there for you to go to medical school. On behalf of Senate of this great university, I hereby declare this inaugural lecture closed.
Please, distinguished ladies and gentlemen, shall we all rise as the academic procession moves out in reverse order.
Yes, ma'am.
Well, thank you very